We should remember, however, that despite of such progress, median survival nowadays of these patients is approximately 7 years. The disease is still incurable, and sooner or later, nowadays rather later, patients will relapse, or some of them are refractory to standard induction treatment. And I think today the main place for new targeted drugs are patients with relapse or refractory diseases. 4 new agents have been approved for mantle cell lymphoma in the last 10 years. First of them was Bortezomib, I mentioned before. It was approved in 2006 for previously treated patients, and more recently was approved for first-line treatment on the basis of the LYM 3002 trial I mentioned before. So Bortezomib is one of the drugs which can be given alone or in combination with chemotherapy to patients with relapsed refractory disease. The second drug is Lenalidomide, also previously used as Bortezomib and approved for Mantle for myeloma patients, but is also active for mantle cell lymphoma patients. And we have now evidence that Lenalidomide gives high overall response rate and high CR in patients with previously untreated and previously treated patients. Even better results can be obtained when Lenalidomide is combined with Rituximab. So recently in the New England Journal of Medicine, Dr. Ruan and colleagues published the results of the phase 2 study in previously untreated patients, and the results are excellent. So 2 agents were used in previously treated patients in the clinical trials, and both are approved for previously treated patients. The third, perhaps most active agent is Ibrutinib. This is BTK, Bruton tyrosine kinase inhibitor, highly active in patients with chronic lymphocytic leukemia and other B-cell lymphoid malignancies, including mantle cell lymphoma. So this agent is approved for previously treated patients and should be perhaps treated most commonly in relapsed refractory patients. So we have now new agents and new possibilities to manage with mantle cell lymphoma. However, not all of them will respond to this therapy, and responses are relatively short. And there are a group of patients who should be treated when relapsed or refractory with stem cell transplantation. I mentioned this procedure as the standard therapy for patients who are younger and who are treated in first line. But some patients did not receive this stem cell transplantation in the induction, and they can receive it if they are fit enough later during the disease course. So autologous cell transplantation is one of the options for relapsed patients. But patients who are chemorefractory and have not other chance to achieve longer response can be considered for the treatment with allogenic stem cell transplantation. This option is the only curative treatment for mantle cell lymphoma. However, this is a very harmful procedure, and the mortality is relatively high, and we should carefully analyze each case, each patient who is qualified for this procedure.